Good evening, everyone. My name is Marco Pech. I'm the stroke program coordinator at Torrance Memorial. And first and foremost, I just want to thank you all for being here this evening with us. This is our first lecture back in person. We're doing a little bit of a hybrid model, or in person as well as Zoom. So those of you, in the virtual space, thank you so much for your time. And we'll discuss a little bit about stroke, our comprehensive stroke program here, some of the management strategies that we offer, and kind of some questions that we can help answer for you at the very end with some of our Q&A. So just want to thank you on behalf of the Miracle of Living Lecture Committee. We do this on a monthly basis. Prior to COVID, it was in person, and now we're transitioning to a hybrid model. So thank you so much for that. Today's lecture topic will be about stroke. Recognizing the signs and symptoms of stroke, acute stroke management strategies, some of the interventions that we offer, and just the full gamut and really the expertise that we can bring to the community and to the South Bay. So today I have Dr. Shlee Song. She's a medical director of our comprehensive stroke program, as well as our interventional neuroradiologist, Dr. Donny Baek. So they'll be going to some of the intervention strategies that we offer here. All right. So stroke. What is a stroke? Well, it's a brain attack. Blood flow to an area of the brain is cut off and deprived of oxygen and vital nutrients. So this lack of blood flow can cause brain tissue injury and potentially irreversible damage. We look at different types of strokes, two different types. We have your ischemic and your hemorrhagic. The ischemic type of stroke, you have a blocked artery inside the brain, which you can see here on this picture on the left. And you have a different type of hemorrhagic stroke, which is a ruptured blood vessel in the brain. 80 to 85% of strokes will be ischemic in nature, this blocked blood type here. The remaining 10 to 15 will be hemorrhagic in nature. Well, why is it important to focus on stroke in the first place, stroke care? When we look at some of the facts and statistics of it, each year, approximately 800,000 Americans experience a new or recurrent stroke. It's the 5th leading cause of death and is the leading cause of serious long-term disability. Between 2018 and 2019, stroke-related costs in the US came to nearly $56 billion. So it's a huge hit, to the economy, to the patients' lives overall. So that's why we try and bring this expert level care to our hospital, to the community, so we can serve the residents in and around the South Bay. You can see that those costs relate to healthcare expenditures, medicines to treat stroke, and then missed days of work. So now we'll switch gears a little bit and talk about Torrance Memorial's comprehensive stroke program. So who are we? Well, we're a nationally recognized and accredited comprehensive stroke center, providing the full spectrum of care for neurological and neurosurgical services to treat complex stroke cases. You can see our team is involved of a multitude of personnel. We look at nurses, ER, ICU, neurologists, interventional radiologists and imaging personnel, neurosurgeons, pharmacists, neurorehabilitation in the form of physiatry, case management and social services, and spiritual care. So it's really a group effort, a team effort when it comes to treating these patients right when they come through our door. Looking at our stroke program scope, it's a comprehensive program that provides a system of care for stroke patients, which promote easy access to the highest, most appropriate level throughout the continuum of care, safe and effective, up-to-date interventions and evidence-based treatment, as well as service excellence. That's what we try and focus on and strive for, and this is really what's at the foundation of our stroke program and our hospital as a whole. And at Torrance Memorial, we're very fortunate in that we have great philanthropic support along with our Torrance Memorial Foundation to really bring the experts to the bedside, as well as the technology to support the interventions that we offer here. And one of those will be our Lundquist Neuroscience Institute. You can also see we also host our Lundquist Laurie Cardiovascular Institute, our Hunt Cancer Center, our burn, wound, and amputation prevention. We're one of 3 burn centers in all of LA County, so we're really proud in that regard. Maternal child services, we have a level 3 NICU here for neonatal intensive care, an eating disorder program, which is nationally recognized, orthopedics, diabetes, bariatrics, and of course, our kind of ambulatory management care with primary and ambulatory services that really focus on the residents of the South Bay. Some of our organizational achievements you can see here. So on the far left, we were fortunate enough to be recognized as one of the world's best hospitals in 2023, as well as 2022 in Newsweek, as well as one of the best regional hospitals according to U.S. News and World Report in 22 and 2023. And one that we're particularly proud of is our South Bay's best with regard to Daily Breeze and the Breach Reporter here last year. Other things that we focus on as an organization is our magnet recognition, and this really focuses on bringing high-level expertise from a nursing perspective, and you can really see that in the care that we provide for our patients and family. And of course, our comprehensive stroke certification and some of those other new U.S. News and World Report recognition, whether it be in stroke or neurology and neurosurgery. So just to really recognize the great care that we provide here day in, day out. We also are a part of a evidence-based management kind of quality initiative that's brought on and really driven by the American Heart, American Stroke Association, and really providers across the country when it comes to these initiatives. So you can see we've been recognized in a multitude of areas when it comes to acute MI, heart failure, and resuscitation, as well as stroke. So really achieving the highest level of quality care with regards to the American Heart, American Stroke Association. So here at Torrance Memorial, what are the conditions that we treat? We treat patients with ischemic and hemorrhagic strokes, patients with the cerebral aneurysms and arteriovenous malformation, intracranial atherosclerotic disease, and carotid artery disease. Some of the specialty physicians that we do have on staff will be a neurologist with expertise in cerebral vascular disease, neurosurgeons, neurointerventional radiologists and imaging, critical care, vascular surgery, and neurorehabilitation. So really providing that full spectrum of care for our patients. Try not to leave any stone unturned. So what does specialty stroke care look like on one of our units? Well, we have neurospecialty trained RNs and staff, up-to-date stroke treatment and management approaches, dedicated inpatient units. Studies have shown that having specialized units with highly trained staff tends to lead to better clinical outcomes or better patient outcomes, and that's really what's at the foundation of it all. We also focus on daily patient-specific plans and collaborative discussions that happen in a multidisciplinary approach. And really at the center of this will be the patient and family. So you can see here all of those specialties kind of working in unison to really focus on the patient and their family. All right, so we're really fortunate enough to have an affiliation with Cedars Sinai for our hospital, and where we're quite intertwined, with regards to patient management and really program development will be in our neurology and neurosurgery services. And one of the things I'll focus on today, we'll be looking at our Telestroke services and how we bring hyperacute stroke management to our emergency department, as well as on the inpatient side, if we suspect, one of our patients in one of our inpatient units may be having a stroke. So in 2016, Torrance Memorial had a partnership with Cedars Sinai to bring what we call telemedicine or telestroke services to the South Bay, and really focusing on cutting-edge acute stroke management and treatment options via telemedicine. So we have stroke or vascular neurologists that are trained in stroke specialty that can consult on patients remotely from any location. So really, these consults, from once we get that acute stroke activation in our emergency department, those consults start within less than 5 minutes. When it comes to stroke, time is of the essence. So we try and work as quickly as possible to get treatment recommendations, act on those treatment recommendations, and then kind of proceed through our plan of care. So really, what it really does is provides ease of access to nationally recognized clinicians with expertise, like I mentioned, in stroke diagnosis, treatment, and management strategies. And we offer this 24/7, 365 coverage for hyperacute stroke care. So whether it's 8 a.m. on a Monday morning or 2 a.m. on a Sunday morning, we can manage those patients at any time of the day, and we have the team to help support that. So what does an acute stroke or a telemedicine consult look like in the emergency department? I'll kind of go through a clinical scenario here. Patient presents with acute neurological symptoms, for example, weakness, difficulty with speech. Those are kind of the main things that you may see. The emergency room team activates that acute stroke response protocol. That emergent consultation that I mentioned starts within less than 5 minutes. goes out to one of our Cedars Sinai neurologists, and we have a physician-to-physician consultation that talks about the patient's chief complaint or their clinical symptoms, and they get on camera and they evaluate that patient. So you can see here, the neurologist will beam on the camera right over here, along with our emergency room team at the bedside to help coordinate that care. So those recommendations and plan of care is discussed with the team, the patient, and the family at that time, and we make recommendations based on that. So a lot of these things happen, patient comes in through the door, we suspect stroke, a whole team assembles to the patient's bedside, nurses, emergency room technicians, our imaging team, and they're alerted of that we have a suspected stroke. That patient gets put on a cardiac monitor, we start to draw labs, get them IVs placed, and we do a quick neuro exam so we can kind of understand the level of severity of those symptoms. That patient gets whisked off to our imaging, our CT suite. We're able to get quick imaging and then really kind of drive the treatment from there. That neurologist will be on camera through the whole time until those recommendations are given to our emergency room physician and team. So when it comes to symptom recognition, we like to use the mnemonic "be fast." So during acute stroke, like I mentioned, time is of the essence. Time is brain. So we want to act as quickly as possible to really maximize the amount of time we're at the bedside. So what does that mnemonic stand for? You can see here, B is for balance. So loss of balance or dizziness. E is for eyes, any vision changes in one or both eyes. Face is for facial drooping. Usually it'll be on one side of the face. A is for arms, so weakness or numbness on one side of the arms as well as the leg. So it typically happens on one side. Speech, trouble speaking, confusion, as the patient slurring their words. And then last but not least is T for time, and really focusing on calling 911 if you suspect someone may be having a stroke. So, be fast is really what we focus on here. Like I mentioned, during a stroke, every minute counts. By knowing the signs and symptoms, you can take quick action and potentially save someone's life, maybe even your own. So what are the key things to remember when it comes to stroke symptom recognition? Note the time when any symptoms first appear. That will be really helpful when talking to the EMS providers in the field and triaging that patient, as well as once that patient comes in through our doors and we're getting that history of when these symptoms started, and that then we can really tailor our treatment management strategies. And you can see here in bold, do not drive to the hospital or let someone drive you. Always call 911. We're really fortunate in LA County that we have a stroke system of care where the providers in the field can coordinate with hospitals to really have that patient go to the most appropriate center that is capable of treating complex stroke cases. All right, well, thank you so much for your time. And I'm gonna introduce Dr. Shlee Song now. Dr. Song, she's the Vice Chair of Systems Integration and Professor in the Department of Neurology at Cedars Sinai Medical Center. She is the Medical Director of the Comprehensive Stroke Center at Cedars Sinai and Torrance Memorial. In addition, Dr. Song directs the Primary Stroke Center at Marina Del Rey Hospital and Providence Cedars Sinai Tarzana Medical Center. Dr. Song is a board-certified vascular neurologist who completed her clinical research fellowship at the National Institute of Health, the NIH, and neurology residency training at George Washington University in Washington, D.C. Dr. Song served on several NIH and industry trial steering committees and served as principal investigator on multi-center stroke trials. In 2015, Dr. Song developed a telemedicine network that delivers acute stroke care to screen patients for emergency stroke treatment and clinical trials at Cedars Sinai Network Hospitals, and Torrance Memorial is one of those. In 2022, over 2,200 stroke codes were covered by Cedars Sinai Telestroke team, with over 200 patients receiving thrombolytic or this clot-busting drug treatment, and over 130 endovascular thrombectomy cases treated across 3 hospitals. Those patients treated just like Dr. Baek has treated before in the past. For stroke systems of care, she co-directs the Los Angeles Stroke Society with physician leaders at USC and UCLA in coordination with the LA County EMS Medical Director. In Dr. Song's teaching role in Department of Neurology, she established the AAC-GME Vascular Neurology Fellowship Program at Cedars Sinai in 2013, training many stroke neurologists that practice in the region and across the US. She currently serves as a special section editor in the AHA Stroke Journal and digital media. So I'd like to welcome Dr. Song.
Thank you, Marco, and great talk. And thanks for walking through a lot of the history and our multidisciplinary team that provides our stroke care. So shout out to those of you online. I got a text from a colleague that lives in Canada. So with Zoom and hybrid learning, we have this is amazing that through Facebook and social media, we have ways to connect that's beyond, and through the pandemic, these connections are still thriving today. So glad for those of you here in person in the audience, and thank you for joining us online. So as Marco said, I'm here to talk about stroke. I'm really passionate about it, and thankfully I've got amazing colleagues to work with that is excited to deliver this life-saving care that we have. It's the 5th leading cause of death. It has dropped now, thankfully, with a lot of the treatments that we offer and what we know now with prevention, that it went from the 4th leading cause of death to the 5th, but still there's a lot of work to be done. It's the 1st leading cause of disability for adults. And I wanted to have us take our judgment aside, because young people and healthy people have strokes too. So when you see these signs that Marco has talked about with Be Fast, it can happen to the best of us when it comes to coming out of the blue. And I have stories from patients where they're working out at the gym on the treadmill and this comes out of nowhere. So I liken hemorrhagic strokes, the 15 to 20% of strokes, to a burning house. And this is what's going on in the brain. Structures are getting destroyed with minutes that are passing by, and you don't hesitate to call the ambulance and firemen to respond to a burning house. Call 911 with any signs and symptoms of stroke, because this could be going on in the brain. What we do as soon as that type of patient comes in, we get the quick head imaging to identify this type of stroke, because a lot of times we don't know and it presents the same way as the other type when blood flow is not going to the brain. So that's why we need to get that head imaging done quickly. And one of the first things we work on in that burning house or that burning, so that hemorrhagic stroke brain where blood is going where it should not be going because it's now through a burst blood vessel, we are working towards getting that blood pressure down. Because what do we got to do? We got to cut the gas line, we got to turn it off. And that's one of the first things that we're doing, is we're working towards getting that blood pressure down, because we know that blood keeps expanding the more time it takes to get that blood pressure down. The other thing that happens is that in the setting of that bleeding type of stroke, we see an electrical fire too. So sometimes these brain waves are firing that are causing seizures. So the shaking and the rhythmic type of shaking, or the tongue biting, or the urinary incontinence, that means when you can't control your ability to pee and go to the bathroom, this may be going on in the background in that setting of that burning house. So with hemorrhagic strokes, we're working on these two things with our emergency room colleagues, getting that blood pressure down and working towards getting the anti-seizure medication, which is similar to quieting the electrical fire here. So hemorrhagic strokes are tricky because, as you know, in the aftermath of a fire, there's a lot of destruction. And our stroke patients that are often young coming in with these type of strokes, it takes many weeks and months to recover. And think about all the cleanup that needs to happen. And that's what's going on in this recovering brain. What can you do now, today, with your loved ones, and taking this information that you have right now is purchasing a blood pressure cuff and recording those blood pressures, so that when you go to see your physician, your next wellness check, you're gonna have some readings of your blood pressure. Hey, in the morning when I'm feeling calm, my blood pressure is about this. I had a really stressful conversation with someone, life stressors happen. Does my blood pressure peak up wildly? Because we know that life happens and the life stressors will continue to come, but having that information to discuss with your doctor the next time you see your doctor is really helpful. And blood pressure cuffs now, I checked on Amazon or the drugstore, you can get a decent blood pressure cuff, $35, $40. And we know that this is one of the things that could be life-saving, because if you treat your blood pressure now, hopefully you will never need us, because blood pressure management can really help save the brain. So this picture, it's not very visible, but that's on purpose because the power is out. And I thought this is a good description of what's going on in the brain when blood flow is not getting there. So I like to compare the brain to your computer. It controls everything. And when the power is out, you don't want to keep the refrigerator open or things are going to spoil, ice is going to melt, your ice cream's going to, spoil. But unlike that fire, we have some time to spare things and preserve things. And so that's why minutes matter. And we're working towards restoring the power when the power is out. So this is the scan that we typically get when you first arrive to the emergency room. And the first case that I showed you was a burst blood vessel that's causing blood to get to the brain tissue where it should not be going. In this setting, the power is out, blood flow is not going to an area of the brain. And the picture on the left side are some early changes that we see. And the picture on the right is sometime afterwards, probably weeks afterwards. And this is the normal tissue. And the more time that passes, it's going to evolve to this. What we're trying to do now is trying to save as much of this as possible by getting that blood vessel open. So there's a famous paper that was written by one of my colleagues at UCLA that minutes matter, and we have demonstrated this with pictures, but they also checked at the cellular level that 2 million neurons die, or cells die, with every minute that passes. So that's why we're working in parallel, meaning there's somebody getting your blood work, there's somebody getting your vital signs and blood pressure, somebody's trying to weigh you, and there's a lot coming in all at once. And I remember hearing from a stroke survivor the other day, they said for us as providers to say, hey, this is scary, we're gonna be working quickly because minutes matter, but I'm gonna ask you a lot of questions all at once. When they heard that, they felt like, okay, you're explaining something to me because I don't know what's going on, but I know this is all towards trying to save my life or trying to save some function that's going on in my brain. So that's something I learned from a stroke survivor that was really helpful in the way I want to practice. So this picture here is demonstrating what we're trying to do by providing a lot of these therapies that we're going to be discussing with Dr. Beck coming up shortly. But that red area is the initial area where the clot went, and blood flow in that region, even with it restored, may not come back. But what we're trying to save is that green spot, or the greenish yellowish spot there. And the more quicker we can do this and more complete we can open up that blood vessel, we can potentially salvage a lot more tissue there and hopefully a lot less disability for our patients. So Be Fast is a different rendition than what we had before, which was FAST. because we know that sometimes blood flow to the backside of the brain has different types of presentation. So a lot of people will recognize, oh, the face looks droopy, or somebody's not talking right, or one side is paralyzed. That I recognize as a stroke, but a lot of people won't recognize, hey, why can't I walk straight? I've had an uncle who lives down the street, who's a physician. He wasn't walking straight, and he didn't recognize that he was having a brain abnormality. Dr. Paula Ebele actually saved his life, but his wife had recognized something's wrong with his walking. Why is he shuffling his feet like that? And it was because the walking was off and the balance was off. So balance is one of the functions of the brain, and it's the backside of the brain or the deeper structures of the brain. Vision. So anytime for stroke, if something is not working right, that could be a stroke, especially if it's sudden onset. And the first picture I showed you, there was a lightning strike there, and that's what it feels like. It just comes out of the blue. So if there's sudden loss of function, don't hesitate to call 911. So the other things I want us to do is use more descriptions when we talk to our emergency room providers. So the emergency room is a very chaotic place. People are coming in for everything. And I want to help out my ER colleagues as much as possible, because I'm feeling dizzy, I'm feeling off. What does that mean? It could be your stomach not feeling right. It could be that you're nauseous because of something that you ate. So when you describe it as my walking is off, I can't walk straight, or I'm dizzy and it feels like I'm rocking on a boat, or my vision is off and when I'm covering my eyes, I can't see out of my right eye all of a sudden. So those are helpful to hear for our emergency room colleagues, and that may trigger our telestroke response because they are now suspecting stroke. The other things with that hemorrhagic stroke, so that's that bleeding type of stroke where there's a burning house. Headache could be anything, right? You missed a meal, you stayed up too late the night before. But if it's the worst headache of your life, and that intensity of the headache started off as a 10 out of 10, describe it as the worst headache of your life. We know that that is concerning for stroke. Talk about your walking. So if your walking is off, say it. Dizzy can be so many other things, and that's why the more descriptions that you have about your loss of function, whatever disability that came on suddenly, that's how you want to talk to your emergency room doctor, your emergency room nurses that are often in the front getting that information. Describing these things can really help trigger us to respond for a possible stroke. So this is that description of your vision being off. It could be your glasses, but take off your glasses. Is it still there? Cover one eye at a time. Is your vision out in one eye or both eyes? Those are all things that we're looking for, and that could be a sign or symptom of a stroke. So in a patient that is having this type of stroke where blood flow is not getting to the vision area of the brain, it looks like this. That picture, those cars are not there. So why would you get in the car and drive yourself to the emergency room? I do have patients where they've done that because it may come on without pain. So, you know, it's a bit embarrassing to call 911 and make such a, this could happen. You can hurt somebody by trying to drive yourself. So that's why also it's really important that you call 911. Here's the other type of stroke. If things are not working right in the brainstem, things can double up. So if you're covering one eye and that double vision goes away, that could be a sign or symptom of a stroke. And how we test for that is having the patients follow our finger, and we can do this on the Telestroke camera as well. We can zoom in on the eyes and check to see if the eyes are moving together or not. The brain controls that. So if the eyes are not moving together, sometimes one is straight while the other one's looking right. For you, your vision will double. And that's when we pick up that there could be a stroke there that's causing the double vision. So this is why calling 911 helps, because we could get to the abnormality that much quicker and work towards whatever is causing the stroke symptoms that much faster. So like I said, strokes can happen to healthy people, young people, and on social media, Justin Bieber went through a stroke emergency with his wife. So Hailey Bieber had a stroke. I believe she's in her 20s. And there are strokes that can happen because a blood clot moved from one area of the body and went to the brain. And I know summer plans are coming up. People are flying to wonderful places like Europe and going all over the place to visit family. Know that when you tip the scales towards clotting, things like dehydration. So people don't tend to drink enough water on the plane. The air is pretty dry up there and you're not moving very much. What you could do is make sure you hydrate well, you move about the cabin when you can, wear compression stockings, and that way blood doesn't pool in your legs, because you probably noticed after a long flight, your legs are about twice the size when you took off. So anytime blood pools in the legs, you could develop a clot in the legs. So wearing the compression stockings can help prevent that. But I suspect that that's the kind of stroke that she had because they fly around everywhere. And then for women, we also have the factor of hormones. And during perimenopause, during our childbearing years, and those that are on oral contraceptives or birth control pills, those can tip the scales towards clotting. And so young people can have strokes too. Don't hesitate to call 911 or get help right away for a young person that has those type of symptoms, the BFAST symptoms. And then we talked about prevention. What you can do today is start recording your blood pressures and talking about blood pressure with your primary care doctor when you go see them next. And then the next story I wanted to talk about was a recent one, because it really was a heartwarming story for me, because I feel that nursing homes and nursing facilities often get a bad rap. But this amazing story came out during the past 6 months, and this caring phone call really helped save a life. So there's a couple where the wife is now in a nursing facility because her memory has gotten poor over the years, and caring for her in the home was at a place where the family thought she would be safer in the nursing home. And the partner, her husband, had a regular routine of showing up each morning at a certain time. When that husband did not show up that day, their nursing home provider thought something is off. He shows up every morning at about this time. She picked up the phone and called the daughter and said, "I think you need to go check on your dad." Well, she found her dad down and called 911. Our Telestroke providers were able to pin down that the last time he was moving everything okay was about within the last 24 hours. So thankfully at Torrance Memorial, we have capabilities with MRI as well to help time whether the tissue is viable enough where we can open up that blood vessel and not cause harm. And we have capabilities to do that now. So we looked at the MRI, saw that he had the brain tissue markers of what looks like an early stroke. And so the patient got the clot busting drug and then an intervention that Dr. Beck is going to talk about next. But the patient was able to walk out of the hospital, and he's in his 90s. So I think about the times when I'm tired or that 2 a.m. call, but I know that these kind of stories come out of the work that we do. And I wanted to thank you all for being here. I thank Marco for the amazing coordination that he does. And really thankful for our IR doctors, because we can be men and stay in our pajamas, but he has to drive in and physically go in and take that clot out. So thank you, Dr. Beck, and thank you to the Torrance team.
Thank you so much, Dr. Song. That was an amazing story. Yeah, I remember being at the bedside for that case specifically. So it's so nice to see that type of outcome. All right, so next I'll be introducing Dr. Donny Baek. He's one of our neurointerventional radiologists, as well as radiologist at Torrance Memorial. Dr. Baek, he received an undergraduate degree in chemistry after graduating summa cum laude from the University of Southern California. He then attended Harvard Medical School, where he graduated with honors and received his medical degree. After medical school, Dr. Baek completed a residency in diagnostic radiology at UCLA, where he served a year as chief resident. He later stayed at UCLA to complete subspecialty fellowship training in cardiovascular and interventional radiology. Dr. Baek is board certified by the American Board of Radiology. He maintains his certificate of added qualification in vascular and interventional radiology as well. Although performing a wide variety of procedures as an interventional radiologist, Dr. Baek has a special interest in treatment of cancer patients, including tumor ablation embolization. He's a member of multiple professional societies and has been an invited speaker on the role of interventional radiology in the treatment of cancer. So I'd like to bring up Dr. Donny Baek.
Thank you, Marco. Thanks. Hi, everybody. Let me see if I can get this to work here. Oh, I got one more slide of yours, your song. So before I begin, I did want to take one moment to acknowledge Dr. Song and Marco and really all of the members and staff here at Torrance Memorial, part of the stroke team, for their hard work and dedication in building this stroke program really from the ground up. I started here in Torrance Memorial in 2008, which means I've been here for about 15 years. And I remember what it was like when I started, how we treated stroke back then. And to see that evolve over the last maybe 5 or 10 years, it's truly remarkable, the impact we can have nowadays on patients who present with these, devastating symptoms. And it's really a testament to their leadership that this program has flourished and blossomed. And I'm so humbled and I'm so proud to be part of such a great program. So anyways, thank you guys so much. So with that, I'll just begin by saying I think we can all agree that stroke is super scary. You could be completely fine and then bam, out of nowhere, you're falling off the edge of a cliff to perhaps, lifelong disability, maybe requiring 24/7 care. You can't, communicate or relate to your loved ones anymore, or you might not even survive the event. And so sadly, once the injury to the brain has occurred, there really isn't much that we as physicians can do to reverse that injury. Yeah, we might be able to support you through that period of the acute phase of the stroke, where the swelling of the stroke might cause other complications. We might be able to treat those complications and get you through the swelling, but the disability and the neurologic deficits that arise might not be recoverable at all. And we might give you an aspirin, we might treat your blood pressure or your cholesterol or your diabetes, but unfortunately, there's little that we can do at that point. So Certainly, if the issue is that there's a blockage in one of the pipes, meaning there's a blood clot in the artery that supplies the brain, perhaps if we were to open that blockage before that injury has occurred and before that disability becomes permanent, maybe we can reverse those symptoms and get you back to where you were before those symptoms arise. So back in the 90s, we started giving patients TPA, which is tissue plasminogen activator, which is basically a medication that we gave through the veins, and it's basically a clot busting medication, and that's meant to dissolve blood clots. And the hope was that some of that medication would percolate through your bloodstream, get to that blockage, and start dissolving that blood clot. And while it was effective for some patients, unfortunately, with patients with really big blood clots, it just wasn't that effective because it becomes diluted by the time it gets to the area of interest. And so, a lot of work was done to see, maybe we could do a little bit better. Maybe if we target that blockage exactly where the blockage is, rather than just pouring liquid Drano into the veins, maybe we can, one, be more efficacious, and two, maybe limit the complications that arise from having the liquid Drano go to other parts of the body that we don't really want that to go to. And so fundamentally, if the blockage is what we're trying to treat, then we could take these little tubes, put them into the artery and advance that tube right up to the blockage. And maybe with that tube, we can maybe inject the liquid Drano directly at that blood clot. And in doing so, one, perhaps increase the concentration of that liquid Drano right at the blood clot and thereby increasing its effectiveness. And two, limit the amount of liquid Drano that goes to other parts of the body and therefore decrease the risk of that in terms of causing a bleeding complication. But, certainly some patients can't get, TPA or that liquid Drano because maybe they have bleeding. Maybe they had recent surgery, and maybe that TPA could cause some catastrophic hemorrhage. So we started using these devices. This is penumbra with a separator wire, and we'd use this little bead-like device that goes through the catheter to try to break up that clot and to break up that clot into tiny little pieces and suck out that clot that way. Then the devices got even more elaborate. We had this device called the Mercy device where it'd be a little coil, and sometimes we have even little fishing lines hooked up on that coil. And then we deploy that coil in the clot, hopefully get it entangled in that clot such that when we pull out that device, hopefully the clot comes out with us and restores blood flow. So, in medicine, when we have these interventions, even though we try them on patients and we see, every once in a while, wow, we have a great outcome, we really wanted to know, are we making a big impact on all patients on average? And so whenever you have an intervention that's new, what do? You have to kind of run an experiment on people. And when you run experiments on people, those are called clinical trials. And basically what a clinical trial is, you take a group of people with a disease, here a stroke, and you divide those people randomly into two groups. One group gets the kind of the standard treatment, the IV TPA, and then the other group gets the intervention. And then you just follow those two groups out and you see how they do and you compare their outcomes. And so in 2013, the New England Journal, which is one of the most respected journals in medicine, kind of in a dramatic fashion, published 3 landmark trials, all at the same time. And to everybody's surprise, those trials showed that the patients who got stroke intervention actually didn't do any better than the patients who got TPA. And this was a shock to everybody. Because we had been doing stroke therapy for a while, we had been seeing good outcomes, but these trials were showing that when we looked at the data, people weren't doing any better compared to the standard IV treatment alone. And so these were really dark times for us as interventionalists because we had this therapy, we knew it worked on occasion, but now we didn't have any data to support it. So what do we do when we're confronted with data that doesn't make sense? As scientists, we go back to the drawing board. We redesign the studies. We try to figure out what in the study that we might be able to change to show that there is a benefit. And so only 2 years after those studies were published, the New England Journal of Medicine then published 3 news trials. And those trials included ESCAPE, Extend-IA, and everybody's favorite trial because of the acronym the investigators came up with, the Mr. Clean trial, showed that at this point that the patients who got the stroke therapy, meaning the intervention where we pull out the blood clot, did better than the patients who got IV TPA alone. And they did so much better that they had to stop these trials because it was no longer ethical to continue the trials and randomize patients into these two groups. We had to now offer this treatment to all patients who presented with a large stroke. So what's going on here? You know, in 2013, there's no benefit, but in 2015, there's suddenly this gigantic benefit. What was going on? Well, on one hand, technology changed. Compared to those first generation devices that I showed you, we started using these devices called stent retrievers, which was basically a stent on a wire. We'd deploy those stents in that blood clot and hopefully get that stent to start to engage in that blood clot, and such that when we pull the stent out, unlike when we deploy a stent in, say, a coronary artery where we're trying to open that up, when we pull that stent out, we want that clot to come out with us. And perhaps these devices were more effective than those first generation devices. But, you know, I think probably even more important than that was that our patient selection became better. We started using in those trials something called CT angiography, which is a specialized CT scan looking at the blood vessels. And those CT angiograms, the investigators in those trials use CT angiograms to confirm whether or not the patients had indeed a large vessel occlusion, meaning a blockage of one of these big arteries going through the brain, as opposed to taking all patients who had suspected large strokes into the angiography suite and trying to do interventions on them, because some of them inevitably had one of the smaller branches out here that were blocked, and their benefit of the thrombectomy might be less because the territory that supplies is perhaps smaller, and the intervention itself is perhaps higher risk because these vessels out here start to get more delicate and fragile. And so after these trials were published, the American Heart Association updated their guidelines, which was a big deal because they hadn't changed their guidelines for the treatment of stroke for a long time. And during 2015, they changed the guidelines to say, basically, anyone who has a large stroke should get endovascular therapy if they meet the criteria that was used in these trials, meaning first, their pre-stroke Röntgen score was 0 to 1, basically a fancy way of saying before the stroke, they were relatively normal or functioning. Their NIH stroke scale was greater than 6, another fancy way to say that their symptoms from the stroke were not just mild, but moderate or severe. Their aspect score was greater than 6, meaning another fancy way of saying that head CT that Dr. Song showed before didn't show those signs of already injury to the brain. We could get to the patient soon enough, meaning that we could get to the intervention within 6 hours following their stroke onset symptoms. And again, probably most importantly, we've confirmed that there truly indeed is a large vessel occlusion on their imaging. And then since 2015 to now, just continuous work has been done to see if we could expand the role of stroke intervention for more and more patients, not just falling into those, those limited categories, but even treating more and more patients who might fall outside of those categories, including in 2017 and 2018, when the Dawn and Diffuse trials were published. We found that stroke intervention, or pulling that blood clot out of the brain, could be beneficial for patients who presented even as late as 24 hours after their stroke symptoms. And the way we would select patients for treatment is using another advanced imaging technique called CT perfusion imaging, where we would do a specialized CT scan where we would determine where the area of decreased blood flow was and compared that to the area where the stroke had already caused injury. And then when we compare those two areas, we look at the mismatch and see if there's a large area of potentially salvageable brain. And then even just as recently as a couple of months ago in February, the SELECT trial was published, where it showed that even patients who already had injury to a large territory of brain, even those patients who got some treatment with thrombectomy did slightly better than patients who didn't get thrombectomy at all. So it is truly an exciting time to be a stroke interventionalist, but now I'm going to change gears a little bit and take you step by step through how we do stroke thrombectomy, with the goal that after I talk about this, all of you will be experts in doing stroke thrombectomy yourselves, so that we can get you to sign up for the call system and get you doing some of our stroke thrombectomies on call. So first, anytime we do an intra-arterial therapy, we have to get into the artery itself, and that involves typically accessing the artery here in the groin. We access the segment of artery called the femoral artery, and we choose that artery because it's relatively relatively large, so it allows us to put some of the larger devices in to give us the flexibility to treat different types of things that we might want to do. And it also is overlying the bone, the hip bone right there, and gives us an ability to compress that artery when we're done to limit the risk of bleeding following the intervention. Sometimes we'll access the artery in the wrist using the radial artery, and we particularly like that artery when we're trying to treat blood vessels to the back of the brain called the vertebral artery or the basilar artery. The downside of this artery is it's a little bit smaller, so it does limit our device selection to a certain degree. And the way we access the artery is that first we'll put a needle into it, followed by a little wire, and then over that wire we'll advance the tube, and that's called the Seldinger technique. What does that look like in real life? Well, here's an X-ray image of the pelvis, and you can see the needle and the wire passing through that needle in the artery. You certainly can't see the arteries under X-ray. You can only see the bones and the bile gas. So here's a representation of the arteries, and you can see where the needle goes into the artery right here into the femoral artery segment. Again, you can't see the arteries under X-ray, so I typically use ultrasound to access the artery. Here on an ultrasound picture, you can see the artery in the vein, and on the next picture, you can see the little bright dot, which is the tip of the needle entering into the central lumen of that artery. And so once that tube is in the artery, now we have access. The goal now is to advance that tube through the artery tree all the way up into the blood vessels of the brain. And can you imagine, this is probably the most challenging aspect of this, this treatment, because we have to make several twists and turns and select multiple branches. Luckily, we have a wide variety of catheters with a wide variety of shapes, and we try to select the right catheter for the shape of the artery that we're trying to pass that catheter into. And like in all things in life, you know, it's rarely as simple as what you see right here. Whenever we get older, for whatever reason, I don't know why, our arteries tend to elongate, and we don't get taller with our arteries. So because they're elongating, they start to form these twists and turns and even form these 360 loop-the-loops that can be a challenge for us to get these catheters through. Probably even more importantly is that the arteries are never smooth like this video. They actually, as we get older, start to form these stalagmites and stalactites, which are also known as atherosclerotic plaques. And so as you can imagine, when we pass a tube through the artery, it's very easy to break one of these plaques off. And now you've got a new embolus in the bloodstream, which can then float somewhere and get lodged somewhere and shut down the blood flow somewhere else. And that's certainly a complication we want to avoid. So what does this look like in real life? So here's the wire passing up the overlying the spine in a segment of artery known as the aorta. And then here's the picture of certainly the face, the neck, and the chest. You see my catheter here in a segment of artery called the aortic arch. Here I've selected a kind of this reverse curve catheter, and I've done that, and now I'm injecting contrast, which is basically a liquid that's radiopaque, so it looks black or dark on our X-ray images. Now with this roadmap, I can advance a little wire through the carotid artery, and over that wire I can advance that tube. And again, I can inject some more contrast to confirm I've selected the appropriate left carotid artery. And again, once I have that as a roadmap, I can advance that tube directly into the artery at the skull base, inject a little more contrast, and now you can see the arteries of the brain. Here is the anterior cerebral artery supplying the inner margin of the brain, and this is the left middle cerebral artery. And now you can see a little problem here. If you can look at this depiction of the normal artery system, where it shows branches supplying the lateral portion of the side of the brain here, which is the major territory of that left side of the brain. In this poor patient, the artery is blocked or is abruptly cut off. If we follow this angiogram out a little bit further, you can see the contrast forming a nice blush of enhancement. That's the contrast filling all those little teeny tiny capillaries in the brain. And you can really see now a juxtaposition of a relatively large area of brain that is completely devoid of that contrast. And you can see how that can go on to be injured and ultimately lead to stroke. So using that as a roadmap for guidance, I can advance that tube right up to the blockage. Here's another picture of it with the tube basically right at where the blockage is. And once we get that tube right up to the blockage, we'll take that tube and we'll hook it up to a pump, just as simple as that. And we'll turn the pump on, and then we'll all hope and pray and just wait. for that blood clot to hopefully get sucked out with that pump. Alternatively, sometimes we will advance a tiny little catheter through the clot itself. And using that catheter, we'll take out the wire that we use to advance that microcatheter through the clot and advance a small stent retriever, which was that device that I showed you before. And when we pull that microcatheter out, that stent retriever will deploy or expand, and all these little tines we hope will interdigitate in that clot, engaging the substance of the clot such that when we pull out the stent retriever, hopefully the clot comes out with it. And this is a picture of that in real life, showing again the blockage here. You can faintly see, I'm not sure this projects well, but we faintly see my microcatheter extending through the blockage. Here I've injected contrast through the microcatheter into the branches beyond the blockage to confirm I'm still in the artery rather than perforating through it. And then using that microcatheter, I've deployed the stent retriever at that blockage site, which is right here. You can see these little fine little dots because the stent retriever is so delicate and fine. Sometimes it's hard to see under x-ray. So you can see the dots here that the manufacturer has placed on the stent so that we can visualize the stent. And then we pull it out and we hope we see something like this. In the aspirate, we hope we see a blood clot, or on the stent retriever, we hope we see another blood clot stuck to it. And if we see this, then everyone in the angiography suite cheers. We all give each other high fives. And then I inject contrast one more time and hope to see this. And you can see now that blockage is resolved. You can see these major branches of the MCA now supplying that portion of the brain that previously had no blood flow. You can see relatively robust blood flow to that area now. So doing this requires certainly x-ray equipment. As I alluded to, we use fluoroscopy, which is basically real-time x-ray. We tend to use biplane when we can do it, when we have it available, meaning have frontal and lateral views at the same time. This allows us to kind of get a 3D representation of what we're doing, even though we can only depict that on two-dimensional imaging or two-dimensional screens. Here at Torrance, we have one biplane suite currently, but we are fortunate with the support of the hospital and the support of our generous donors that we're able to open up a second angiography suite, which should be coming online, I think, in like maybe 6 months or so. We're in the construction phase and the installation phase. And as you would imagine, this new angiography suite is going to be the latest and greatest in terms of the imaging train. Not only the fact that, you know, it's going to be better visualization, better clarity at reduced dose. The imaging clarity gives me the confidence that I can see what I'm doing, and I feel more confident that I'm doing the right thing for the patient. But also will be coming with a large suite of extra functionality, including doing things like CT perfusion on the angiography table rather than going down the CT, some specialized stent and aneurysm coil planning, or even some interventions outside the brain, including spine intervention and some body intervention. So it really is an exciting time to be a stroke interventionalist here at Torrance Memorial, and I'm so proud and so thankful to be at such an institution like that. So thank you, everybody, for your time. And again, if anyone wants to sign up for the stroke call, I hear Christmas and Thanksgiving are still up for grabs, so you can kind of find me afterwards and sign up. Thanks, everyone.
All right, thank you so much, Dr. Baek. So we're fortunate here at Torrance Memorial to have 5 interventionalists on staff to help us support our stroke program, as well as a multitude of other interventional radiology procedures that we do here. So very grateful, very thankful, and very lucky in that regard to have such expertise at the bedside, whether it be for stroke neurology or interventional radiology, to really maximize, you know, our patient outcomes. All right. So now we will switch gears and go to a little Q&A, from the people in attendance here today. But I did have one question from our people in the virtual space. And one of those, let me get the exact quote for it. So the question was, how do statins play a role in stroke prevention? I've seen news articles on social media talking about their side effects.
I can take that one. So Dr. Beck gave a great picture of what it looks like in the arteries with the stalactites and stalagmites that are coming and blocking the entryway into a blood vessel. That's very much what we see in patients where high cholesterol, especially the LDL, is what contributes to that process. So when you get your blood test and your doctor is going over your cholesterol results, that LDL level is what tends to develop that type of process in your blood vessels in the heart and often in the brain too. And the statin medications, with all the studies that we have seen, they bring that process down or slow it down. And what we've seen also on the microscope is that the spikiness of those blood vessels. So if any of those break off and go downstream and go up to the brain, it can cause that type of scenario where it's blocking blood flow to the brain because it's blocking flow. It's blocking that opening. And statin medications basically help smooth that out, decreases the inflammation or the swelling and the blockages there. And then the ongoing process of high LDL can contribute to more of that accumulation over the years. It's really important once you're on the statin that you don't suffer one of the side effects of it. So it's more rare, but sometimes your liver, in breaking that medication down, can cause some inflammation there. And you're a primary care doctor, you're a neurologist, you're a cardiologist. There are ways for us to check your blood to make sure you're not having any toxic effects to your liver. The other things that can happen, very rare, but you can get muscle breakdown from a statin medication too. But these are all things that we can check for with symptoms. We can hear you for any possibility of these side effects, and we can check with blood tests. So with anything that we do, if we don't check it and if it's not in balance, even water can hurt us. So I think if you use the statins carefully and you do it with the consultation of your doctor or your NP or your PA, there are ways to take it safely.
Great, thank you so much, Dr. Song. And to piggyback on that, there's been a lot of kind of discussion in the media about daily aspirin, and there's been a lot of discussion about not taking it. Can you provide a little bit of context about that?
That's a great question, and I'm glad you brought that up, because that article that was in the New York Times, Washington Post, it was highlighted everywhere, but the caveats weren't there of who we're talking about. And I've had several stroke patients where they should be staying on that aspirin, stop it from hearing this news. So if you do not have these risk factors for stroke, you should not be taking aspirin without consultation with your care providers. Aspirin is a powerful medication. It thins your blood, and if you have a stomach ulcer, you can continue to lose blood and prevent the healing from taking that daily over-the-counter medicine. So aspirin, even at that small dosage, is a very potent drug. But if you've had a TIA, so that's a warning sign for a stroke, or the cardiologist put in a stent, meaning one of those devices that stays in the heart to keep the vessel open, it's imperative that you stay on the aspirin. It's very effective in preventing clotting from happening. And for those patients that have had a clot in the past, even if you have not found the cause for the clot, we know that medication helps prevent a stroke. And you should stay on the aspirin unless advised to hold it for some reason. And there are times where you're getting a dental procedure and you have dental implants planned. Then your dentist may ask your doctor to hold your aspirin for 5 to 7 days so you don't have a bleeding issue for that procedure. You should go right back on the aspirin. So stopping aspirin should always be discussed with the physician first, or the NP or care provider first.
Great, thank you so much, Dr. Song. It's a question for Dr. Beck. Are there areas of the brain that are more susceptible to those large types of strokes? And what are your kind of management strategies for those?
I'm not sure I understand the question completely,
Like,
but fundamentally, a stroke is, in this case, what we call an embolic phenomenon, meaning there is a breakage or a blockage that occurs because of some material that has traveled from somewhere else. And that could be from the heart or the aortic arch or the blood vessels in the neck. If that, whether that be, one of the plaques along the wall of the artery or an actual blood clot that is actually from one of the chambers of the heart, those things can, travel in the bloodstream and then randomly basically go to anywhere in the body. And so it's almost like bad luck that it happens to go to the brain. To a certain degree, the brain gets so much blood flow that there is a predilection for some of these things from the heart to go to the brain, but there's no stopping that clot from traveling and passing those branches and going down into the gut, going down the leg, or going down to any other part of the body where they could cause a similar complication. It's just when one of those emboli are small, they could be clinically silent in other parts of the body, meaning that you wouldn't even know it happened, and it would resolve on its own. But in the brain, because it's so sensitive even to a small embolus, they can be very, very symptomatic. Typically, because the carotid arteries are large and get a lot of blood flow, we do see more of those large clots going into those arteries or the distribution of those arteries. But certainly we see the blood clots going to the back of the brain as well in the vertebral arteries and basilar artery. And so, I think ultimately, you can get these emboli going pretty much anywhere. It's very common for these atherosclerotic plaques to start in the carotid arteries, which is why frequently you'll hear people getting ultrasounds of their carotid arteries to look for the plaquing in that area. But like I said, it can travel anywhere, and sometimes it's just luck of the draw where it ends up.
Excellent. No, thank you for that. I know you talked a little about the new angio suite that's getting built. What about the technology of the stent retrievers or the suction catheters? How has that kind of changed over the past several years?
Yeah, there's been a lot of work hand in hand with the physicians and industry in terms of improving the technology that we have to treat stroke. I remember back in the day when we used to do this before, we were using catheters and sheaths that really were never designed to go up this high into the arch or into the brain. And some of those ultimately were very stiff and frankly, a little bit dangerous in terms of injuring the arteries as we were trying to get up into the head and neck area. Nowadays, the catheter technology, it ultimately still is just a little tube, but the industry has managed to find ways to stiffen the back end of the tube that gives us more pushability, where at the same time making the end of the tube that goes into the brain much more soft, much more atraumatic, much more flexible, that it really allows us to get further and further distally into the smaller and smaller branches of the brain. And ultimately, we may have studies coming out that show benefit with these even smaller vessels as well. And so again, we may be expanding the role of this treatment to even further and further territories out in the brain.
I wanted to piggyback on what Dr. Baek is talking about and his talk that went over all those clinical trials. Really want to thank the patients that enrolled in these studies that helped us learn from each of those experiences, that sharing data and really helped us move the needle here when it comes to stroke care. It could not have been done without patients and family members that wanted all of us to learn more of why it worked or why it didn't work. And I think there's such a movement now towards getting more diversity in our clinical trials, because a lot of the statin medications, women break it down differently, but we don't know enough about statins and the way it affects women, because our hormonal differences and the way we age is different than men. And a lot of the drug trials were done on men that were 65 to 70. So I really encourage you to think about participating in clinical trials that really help us learn more about how we do stroke care. And I really appreciate that you brought up those trials with us, because in the span of just a couple years, we learned so much. And it was really the conservative effort across the United States, through Europe, Canada, and really a global effort to change stroke care in just a few years.
Yeah, absolutely. I know there was a stroke trial that was ongoing during COVID that just recently finished up, that may even open up, the care that we may be able to provide for other patients. So, more to come on that one, but, it's really a dedication to the patient, the family, and being able to participate in those stroke intervention trials. I do have another question here. So it says, some of us take a statin to control cholesterol. Do you see any benefit for someone to take a blood thinner like Eliquis to reduce stroke risk?
Yes, those medications that thin the blood, like Eliquis, or the generic name for that is apixaban. You might have seen it on the evening news. I tend to see it there. Those medications are powerful, and they are very powerful in terms of preventing clotting, and the bleed risk could be higher than that of aspirin alone. So it's always in consultation with your care providers, because that indication is typically for those that have a clotting problem due to an irregular heartbeat condition called atrial fibrillation or atrial flutter. So that's when the heart beats irregularly, and sometimes the blood flow does not go through the heart in a fashion where flow is happening well and there is no backfilling. But anytime blood sits still for a while, and I talked about being on a plane or a long flight, it tends to clot. And with irregular heartbeats, the flow does not happen readily and smoothly, and those irregular beats can sometimes mean there's blood that pools in the heart chambers, and that's how clots form. Medications like Eliquis will help prevent that, and it's more effective than aspirin alone.
Great. Thank you, Dr. Song. And one last question here. This one's from our people in the virtual space. If a patient had a stroke, what is the chance of a stroke to reoccur?
Yes, that is a tough question because it is higher. So once a stroke happens, you're at higher risk for another stroke. And those that are the highest risk are those that have a lot of the blockage in the blood vessels, or atherosclerosis, the stalactites and blockage in the cave there. Well, that's what's going on in the blood vessels. And if one ruptured, another one could potentially rupture too. And so we do things like putting patients on aspirin and Plavix to reduce that risk of stroke. We know that Plavix and aspirin, so those are two blood thinners that work similarly, but we know that if we can do that for a short period of time, we can bring down that recurrent stroke risk rate. And we know that typically is the highest in that first month, first week. So we are talking about odds, and what your doctors and nurses and your pharmacists, what we're doing is we're weighing the risk of something and the benefit of something. And we know that when one has had the stroke, where it's that type of stroke, where it's the buildup in the blood vessels, we want to go hard in the beginning and do the two blood thinners, and we may quickly get those blood thinners to a range where it's very effective in your bloodstream. So your loved one or the patients are on a higher dose of the medication on day one, and then we got that level to a level where we want it, so we're reducing that risk of stroke, and then we're running all the tests. We're checking for a clot in the heart, we're checking for an irregular heartbeat condition, we're doing all the things necessary to see, do we need to change the way we are preventing stroke here? We check the blood for cholesterol levels, and we check to see if medications like Lipitor or Crestor are needed. And we tend to go hard in the beginning, meaning the higher dose in the beginning, because we're most concerned about that scenario, that recurrent stroke scenario, because we know that's higher right after that stroke event. That's why the medications go strong in the beginning. And then once we know you're more stable, we pull back on a lot of those medicines.
Thank you, Dr. Song. All right, maybe one more question I think we have time for. So what other kinds of preventative measures do you recommend other than monitoring your blood pressure?
So all the things that we know are good for our heart is also good for the brain. So physical activity, get your half-hour walk in at least daily, mix it up and build a little bit of a sweat there. Good sleep is important. A well-balanced diet is important, and this is all good for the brain and for your heart and good for the mind. Staying connected, so this connectedness, those phone calls, having a routine, and then checking in on each other. I think that's super important too, because loneliness, and as we age, sometimes we feel more and more disconnected. So having friend groups and having regular sessions where, you know, if there's a hobby, a book club, signing up for art classes, I think those are all things that are part of brain health and wellness. And then taking your medications as prescribed and your blood pressure, and then be very gentle with the neck. So Dr. Beck showed those blood vessels. You see these critical blood vessels are here in the neck, and they're very susceptible, meaning for any quick turn or twisting actions could really damage these blood vessels, and it can happen to young people too. So I recommend being very gentle here with the neck. I do not recommend any chiropractic neck manipulations, because that quick turn or cracking the neck, by the way, you shouldn't do that, because there are critical blood vessels here and it's very close to the bone. So some wrong move and it could really injure that blood vessel. So those are ways to prevent a stroke.
Awesome. All right. Well, thank you so much for your time, Dr. Song and Dr. Beck. It was really informative. It's great to see kind of all the programmatic development that's gone over the past several years, and really expanding the time with which we can intervene for stroke. That doesn't mean to take, you know, tons of time when you start to recognize those symptoms, but to come in right away to really, help improve the level of, or decrease the level of severity of that stroke if you suspect it.
And I really also want to, I'm glad that you had mentioned the Lundquist and a lot of the donor support that we have here. So thankfully our philanthropic funds have funded things like the hospital's efforts to increase the technologies that we have and the new angio suite. Those machines are $1.5 million a piece. Very expensive equipment. Each of those catheters, a lot of technology and research and time and effort went into that. And I know all of that wouldn't be possible without people that are investing in the care here. So
yeah, it's great community support, you know, and really just want to thank you all for being here tonight and spending some time with us to learn a little bit about stroke. So thank you so much to everyone. Have a great evening.
So when you